vitreous cells. So this is as the history suggests, 2 days following cataract surgery, endophthalmitis. The diagnosis, spot diagnosis, endophthalmitis. Now, what we do for endophthalmitis, firstly mark the important topic. We know, as I mentioned earlier, we'll jot down the important topics. So the important topic first is the embryology, next is the endophthalmitis. Now in endophthalmitis, what you have to learn is the endophthalmitic vitrectomy study. It is known as EVS study, endophthalmitis vitrectomy study. The first step in EVS study is always check the visual acuity of the patient. You can be asked in the question, a patient of endophthalmitis came, what is the next step you will do? The next step or the first step you will do is the visual acuity assessment. Okay, first step is visual acuity assessment. Now, what does this study says? That if the vision is more than or equal to hand movements, if it is more, that is better or equal to hand movement, what we are going to do, we'll do the vitreous step for the microbiological examination and will give the patient on intravitreal antibiotics. Next, it says that if the vision is only perception of light, no hand movement, only perception of light, we'll do vitrectomy and we will give intravitreal antibiotics, but we'll do the vitrectomy. If there is no PL, even perception of light is not there, the eye is blind eye, what will we do? We'll do the enucleation. We'll do the enucleation. Now, another one thing important is, if there is panophthalmitis, if endophthalmitis has gone into panophthalmitis, enucleation is contraindicated. So the next thing you want to learn or you have to do is the indications, contraindications of evisceration, enucleation. Because if there is panophthalmitis, we do evisceration. We do not do enucleation. We do evisceration. So the next important topic is the indication and contraindications of the destructive procedures of the eye. Okay. Now in this question is, the patient options are antibiotics, mannitol, eye parent patching, intravitreal steroids. So what we are going to do is we'll do the intravitreal antibiotics. No mention about the vision has been given, and the other options obviously we are not going to do in endof. So the answer is antibiotics. Now, most common cause of endophthalmitis is staph epidermidis. But if the question is asked post-traumatic endof, then the answer will be Bacillus cereus. If the most common cause asked is in immunocompromised patient, the answer will be Candida. And if you are given in the question that patient had an after cataract, he underwent treatment for the after cataract, treatment for and after cataract, that is NDA capsulotomy, and after that patient came to you with vitritis, decreased vision, then you will suggest or you will diagnose endophthalmitis by Propionibacterium acnes. Okay, so these are 4 important one-liners in endof, and these are the treatment modalities. And first step is visual acuity assessment. Now, differential diagnosis of endof is corneal ulcer, uveitis, and one important is toxic anterior segment syndrome. Toxic anterior segment syndrome. Okay, TAS. And important diagnostic or the differential about endof and TAS is that in TAS, posterior segment is not involved. There can be hypopyon, corneal edema, anterior uveitis, but posterior segment will be clear. There will be no vitritis. Okay, now let us go to third question. So the first important topic we did post-operative endophthalmitis. You have to learn it, important topic. Next is the cataract surgery. Now, cataract surgery is a very important, because in lens, nowadays, the trend is that the questions are asked about the cataract surgery, its steps, its complications, formula for calculating IOL, different types of IOLs. So in lens, cataract is the major trending topic. Okay, cataract surgery, not the type of cataract they were asked earlier. Now the trend is toward the surgery of the cataract. Now, which step is being shown in the image? This image is shown about the capsulorhexis. This is a flap in the anterior chamber showing capsulorhexis. Now, these are the steps of the phacoemulsification. First is the clear corneal incision. This is the capsulorhexis. This is hydrodissection. We are separating the nucleus from the cortex with the help of a wave of fluid. This is hydrodissection. This is hydrodissection. And this step is formation of a groove. See, there is formation of groove. Two perpendicular grooves are being formed. And this is known as divide and conquer technique. Divide and conquer technique of the phaco. And this is the phacoemulsification. We are emulsifying the nucleus. And this is the aspiration of the cortex. Aspiration of the cortex. Now, you also have to learn about the complications of the cataract. Okay, these are just the questions of just one important topic, but you have to revise the whole topic. So you have to revise the surgery as well as the complications of the cataract surgery. And one complication we did, that is the post-operative endophthalmitis. Okay, now the next question is example of simple myopic astigmatism. Now, this is the diagram I have made about the simple, compound, and mixed. There are three types of astigmatism retinoscopically: simple, compound, and mixed. How to remember is simple is, in simple, one eye, we know that in astigmatism, what is happening? There are different powers in the different meridian. Okay, so one axis has emetropic. Okay, one axis is emetropic, other can be myopic or hyperopic. Other can be either myopic or it can be hyperopic. So it is simple. If it is compound, then both will be myopic or hypermyopic. So people living in a compound, they always stay together. No, so either it will be myopic, both will be myopic, they will be in the same direction. Either both will be myopic or both will be hypermetropic. Mixed, as the name suggests, mixture is always of dissimilar things. Okay, so mixed is one will be myopic, other will be hypermetropic, and in simple one will be emetropic. So these are the three types of astigmatism in the retinoscopy. Now we have been asked not the example, we have been asked the treatment. If there is simple myopic, it means one is emetropic, other is myopic. So the first option is treatment with spherical lenses. We know that we treat myopia with minus lenses. This is gone, plus lens. C is treatment with spherical lens. Now, this can be confusing. B and C can be confusing. Now, it is asked as simple myopic, but it is astigmatism. No, it is not myopic. If it is only myopic, then we'll treat with minus sphere. It is astigmatism. This is astigmatism. Okay, this is not, it will not be treated by sphere number. It has to be treated by cylindrical. So the answer will be treatment with cylindrical, plano, and minus. One axis will be treated with minus and one will be treated with plano. It is astigmatism. So it will be treated with cylindrical, plano, and minus lenses. It will not be C option. Okay, the answer will be B, because it is astigmatism. And this type of option, plus minus on both 90s and 80 degrees, will be the treatment for mixed astigmatism. Is it clear? Is this question is clear? Any doubt? Any doubt on this question? Or shall I move for clear now? Okay. Or you can be asked, this is the treatment. You can be asked about the example, out of which of the following is an example of compound astigmatism. Okay, this is an example of simple astigmatism. Okay, this is an example of mixed astigmatism. Okay, so you can be asked about this, or you can be asked about compound, which is the example of compound myopic astigmatism with the rule. So you all should know what is with the rule and against the rule. With the rule is when the anteroposterior, okay, when the anteroposterior axis is steeper and the nasotemporal is flat. This is with the rule. In against the rule, nasotemporal is steep. Okay, so this will be the with the rule astigmatism. This is an example of, because this is steeper, anteroposterior is -4. It is steeper than -2. So it is an example of with the rule astigmatism. Okay, this question we discussed in TNT, so you can go for it. Next is the Yolk muscle for right lateral rectus. Now, what is the Yolk muscle? Firstly, what is Yolk muscle? Yolk muscles are a group of muscles, one from each eye. They are not present in the same eye. They are one from each eye, which act simultaneously. They will act simultaneously in the version movements. So if this is my eye, okay, I have to look towards this, okay, towards this side. So this movement will happen with the help of right lateral rectus and left medial rectus. So right lateral rectus and left medial rectus are the Yolk muscles, because they are helping in this movement in dextro. This is the dextro version. They are helping in dextro version. So they are Yolk muscles. Now you cannot remember every muscle by making diagram in the exam. So it is a simple way to remember the Yolk muscle is, we remember Yolk muscles with the help of cardinal gazes. Now, what are cardinal gazes? These are the gazes. They are 6 in number. These are the gazes which help, which allow the examination of the ocular muscles. They allow the examination of the extraocular muscles. 12 extraocular muscles. They are the cardinal gazes, which are 6 in number. Now, if we draw the cardinal gazes, this is the central point, and if we draw them, 3 from this side and 3 from the other eye. If I write, this is the right side, this is the left side, right superior rectus, abduction, right lateral rectus, right inferior rectus. Okay, same goes with left superior rectus, left lateral rectus, left inferior rectus. Okay, now to know the Yolk muscles, what you have to do is just do the opposite. Just do the opposite and you will get the Yolk muscles. How? What is the opposite of this RSR? It will be left inferior oblique. Left medial. Oh, sorry. This will be, okay. This will be left. Okay, you will get the left, because the abduction will be done by the medial rectus, only the left medial rectus. This will be left. What will be superior? Left superior oblique. Right inferior oblique. Right medial rectus. Right superior oblique. Is it fine? You just have to do the opposite of the muscle and you will get the Yolk muscles. So the Yolk muscle for right superior rectus will be left inferior oblique. Okay, the Yolk muscle for left superior rectus will be right inferior oblique. Just do the whole opposite. Left to right, superior to inferior, rectus to oblique, you will get the Yolk muscles for the. Okay, so you just draw this diagram. Any of the Yolk muscle is asked, you just draw this diagram and you will get their Yolk muscles. Okay. Fine? Is it fine? You just have to do the opposite of the muscle. If the muscle is right superior rectus, it will be left inferior oblique. Just the opposite, left inferior oblique. Okay, so right superior rectus Yolk muscle is left inferior oblique. Okay, is it fine? This will be okay. Now, the next question is last vision to go in glaucoma. The last vision to go in glaucoma is, now we know that this is a diagram we have studied about the visual field defects in the glaucoma. We know that the last field to go in glaucoma is always the temporal. We know that, no, it's not nasal, it is the temporal. Last field to go is in temporal. We know that there is IS-NT rule. IS-NT rule is what? Thickness of the neuroretinal rim. This is the optic disc, this is the optic cup. Thickness of the neural rim is governed by IS-NT rule. That is inferior, superior, thicker, nasal, temporal, thinner. This is the IS-NT rule. But in glaucoma, this rule is defied. This is defied. So first to go are inferior and superior. First to go are inferior and superior, then nasal, and last to go is temporal. Last to go is temporal vision. There is always a temporal island of vision present. See, we know that in retina, we know that blind spot is what? Blind spot is optic disc. We know that macula is situated in the temporal side of the retina, and the part of the retina, we always know that it forms the image in the opposite half. Macula is in the temporal side of the retina, so it will come under which type of vision? It will come under the nasal side of the vision. Optic disc is present medially to the macula. Normally in the anatomical position, optic disc is nasally to the macula, but in field of vision, it will be present temporally to the macula. So whenever we draw these visual fields, we always draw blind spot or the optic disc in the temporal side. And whenever we discuss about the visual fields, we always draw the visual fields nasally. Have you ever noticed we always draw them towards the nasal side? Because the temporal side is the last vision to go. This is the temporal side, this is the nasal side. We always say that first is the paracentral scotoma, then it is the sedal, then it becomes arcuate, double arcuate. Okay, then is the whole tubular vision comes. So the last vision to go is the temporal, because it defies the ISMT rule present in the neuroretinal rim. It defies it. It disobeys the ISMT rule. Is it fine? So the temporal is the last vision to go. Okay. Glaucoma. Next is the anti-glaucoma drug. Anti-glaucoma drugs. Recently, there is a trend that anti-glaucoma drugs are commonly asked in the question. INI also, NEET-PG also. So do study anti-glaucoma drugs by heart. Okay. So the question is, which anti-glaucoma drug causes ocular hypotension with apnea in infant? Yes, the answer is right. Vivek, the answer is right. It is brimonidine. Brimonidine is alpha-2 agonist. It can cause apnea in infants, so it is contraindicated in infants. Now, anti-glaucoma drugs, very, very important. Now, we know that what is happening in glaucoma is rise in IOP. There is IOP rise. So what we can do is, no. ISNT rule is not this. ISNT rule is thickening of the neuroretinal rim. See, this is optic cup. This is optic disc. This is optic cup. What is ISNT rule is, I think my video is lagging. Okay, this is optic cup. ISNT rule says that the inferior, superior, nasal and temporal. Okay, these are the thickness of the neuroretinal rim. ISNT does not say about the vision. It is the thickness of the neuroretinal rim. Okay, and it is defined in the glaucoma. The inferior one, the inferior and superior are the thickest neuroretinal rims, but they are the first to go in glaucoma. That is why we say in glaucoma there is vertical elongation of the optic cup. Okay, inferior and superior are otherwise the thickest ones. Nasal and temporal are thinner, but inferior and superior are the first to go. They are first to go in glaucoma. That is why there is vertical elongation of the cup. So it defies the ISNT rule. Okay. Now, so the anti-glaucoma drugs, what we can do is either we decrease the production or increase the flow. There are two main things we can do to reduce the IOP. So for the decreased production, you have three drugs. ABC. You have three drugs. The mnemonic is ABC. Alpha agonist, AA. Alpha agonist, BB. Beta blockers. And carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. Okay. Beta blockers, timolols. Alpha agonist, brimonidine. Okay. Carbonic anhydrase, acetazolamide, dorzolamide. One thing to learn about in carbonic anhydrase are they alpha agonist, beta blockers. Both are given topically. All drugs are given topically in glaucoma, but carbonic anhydrase can be given topically or orally, because acetazolamide is given orally. It is not given topically. Rest other dorzolamide, brinzolamide, they are given topically. Okay, so decrease production, ABC. Next thing we can do is increase the flow. Now we know that there are two types of flow in the aqueous. Normal drainage is by either uveoscleral outflow or trabecular meshwork outflow. Trabecular meshwork outflow is the more, 70 to 80%. Uveoscleral is 20 to 30%. There are two types of drugs. PGF2 alpha, prostaglandins, you can be asked which type of prostaglandins. F2 alpha, F in prostaglandins, F for increasing the flow. So PGF2 analogs, that is latanoprost, travoprost. These are the prostaglandins which increase the uveoscleral outflow. The next is the trabecular meshwork outflow. It is by meiotics. You can remember this, or even you can say that in meiotics it is increased outflow by TBM. Okay, so meiotics increase outflow by trabecular meshwork. So meiotics, IOT. In meiotics there is IOT, increase of outflow by TBM. And this is meiotics, that is pilocarpine, carbachol, pilocarpine. These are the examples of meiotics. Now, two things to learn, just revision, is drug of choice. Drug of choice in open angle glaucoma are PG analogs, latanoprost, travoprost. They are the drug of choice in open angle glaucoma. Next important thing is, recently asked in INI about the nitarsudil. There was a question was, which of these drugs causes the aqueous outflow increase by trabecular meshwork? The answer was nitarsudil. Basically, nitarsudil is a recently added drug. It basically acts by, its mechanism of action is that it is a Rho kinase inhibitor. It is a Rho kinase inhibitor which acts by increasing the trabecular meshwork outflow. So it is important because it has been recently added and has been recently asked also, nitarsudil. Okay, always remember nitarsudil, Rho kinase inhibitor. So just remember all the anti-glaucoma drugs. One or the other question is always asked about the pharmacotherapy. Okay, so the next question is, third nerve palsy in diabetes mellitus characteristically shows. Now, we know that third nerve is basically an efferent nerve. It is an efferent nerve supplying the extraocular muscles and also the parasympathetic supply to the pupil. There is parasympathetic supply and extraocular muscles, also LPS. Now, when we discuss about the third nerve, basically in the center, the fibers for the motor supply are there, supplying the extraocular muscles. And in periphery, there are the fibers which supply the parasympathetic system. Parasympathetic system, P for parasympathetic, P for periphery. The fibers having parasympathetic supply are peripheral in the nerve, and the motor supply, they are in the center of the nerve. Now, what is happening in the diabetes is basically, we know that we have always read about the diabetes as the third nerve palsy with pupillary sparing. We have always learned this, that diabetes shows third nerve palsy which is pupillary sparing. Now, what is happening is, whenever suppose there is an intraocular space occupying lesion, okay, intracranial space occupying lesion it is present, so it will compress the nerve. So it will compress the peripheral fibers first and then the motor fibers. So in any intracranial space occupying lesion, there will be pupillary will be gone because of the parasympathetic supply. It will be gone first and then the extraocular muscles. But in diabetes, the peripheral nerve is spared. The peripheral nerve is spared because diabetes is a vascular disease. Diabetes is a vascular disease. So it affects the motor nerves of the third nerve. It affects the motor nerves or the central part of the nerve because of its vascular nature. So it does not cause the parasympathetic supply defect. So there is pupillary sparing third nerve palsy. There is pupillary sparing third nerve palsy that is characteristic of the diabetes mellitus. But in ixoles, in space occupying lesions, in tumors, the peripheral system, because of the compression by the tumor, the peripheral supply or the peripheral fibers will be defected first. They will be affected first. So there will be pupillary sparing will not be seen. There will be pupillary damage will be seen. So the question is, third nerve pulse in diabetes mellitus shows light reflex absent, accommodation present, light reflex present, accommodation absent, both present or both absent. Can you please type quickly? Okay. Any other answer? Basically, see, both, see, light reflex and accommodation, both are the function of what? Pupil. Both are the function of pupillary. These are the efferent supply of the third nerve. There is no pupillary defect seen. Answer will be both present. Yes, because it is pupillary sparing. There will be only ptosis. Eye will be down and out. There will be ptosis. There will be loss of movement of the medial rectus, inferior obliques, superior rectus, but there will be pupil will be normal. So both light reflex and accommodation will present. Both will be present. Okay, just mark this question. This is important because if the question is asked about an ICSOL, intracranial space occupying lesion, then both light reflex and accommodation will be gone because it will affect the parasympathetic supply. But in diabetes, it will only cause ptosis or the muscle palsy. It will only cause the extraocular muscle palsy, not the pupillary involvement will be seen. It is third nerve palsy, which is pupillary sparing. Next thing you can also be given in the question is that a patient for third nerve palsy came, or a patient of ptosis came to your OPD, you diagnosed him with third nerve palsy. The patient gave you the history of diabetes mellitus. What is the next step of management? Option will be given. You will suggest him MRI. Okay. You will ask the patient for his glycemic control, wait and watch. What will be the answer? You will not advise him for MRI because there is history of the diabetes, and on examination you will see that there is only ptosis. The pupil is normal. The pupil is normally reacting. So you'll not, there is no need of going for MRI. You'll just give him the glycemic control or keep him on follow-up. But if there is pupillary involvement is there, we will make him go for urgent MRI to diagnose any space occupying lesion. Then the patient will have to undergo urgent MRIs. Okay. So this type of question framing can also be given in the question. Okay. Now, the next is, a middle-aged female with rheumatoid arthritis presented with the following. This is the slit lamp picture given. What is the condition shown here? Actually, this is a confusion type of question. You can easily rule out melanoma and Tranta dots seen in weak age. Melanoma, yes, melanoma can be confusing because there will be pigmented lesion, but one thing you will see is in melanoma, there will not be elevated lesion. Okay, it will not be elevated. Okay, I'll repeat it. See, basically, the third nerve, what is happening is third nerve, it is supplying two things: motor supply to the extraocular muscles and parasympathetic supply. Okay, the parasympathetic supply fibers are present on the outer side of the nerve, and motor supply is present on the inside of the muscle. If there is a tumor to the patient, it will compress the nerve. So it will affect the peripheral fibers first. So the pupil will be defected. If the tumor is large, it will affect the peripheral fibers, also the central fibers. So the patient will present to us with third nerve palsy like ptosis, down and out eye. And on examination, there will be pupillary reflexes will be lost. So we'll diagnose the patient with ICSOL, we'll get the MRI done. But in diabetes, what is happening is diabetes is a vascular disease. It is a vascular disease. So it will affect the vascular supply of the nerve, which is present in the center of the nerve. The vascular supply is present in the center of the nerve. So it will affect the motor fibers first, and motor fibers are supplying the extraocular muscles. The peripheral fiber will be spared, so the pupil will be spared, but the extraocular muscles will be gone. So in one sentence, we study is that third nerve palsy in diabetes is the pupillary sparing palsy. This is the summary. This is the crux of the question, that third nerve palsy in diabetes is pupillary sparing. This is the crux of this whole thing. Okay. Third nerve palsy is pupillary sparing. Rest things will be there. rest things will be there. There will be ptosis, there will be down and eye of the muscles. Okay, so the pupillary sparing will be there. Yes, but for accommodation, convergence is needed. That is that is a step of the accommodation. That is a prerequisite for accommodation. But if convergence is not there, suppose convergence is not there because of the MR medial rectus is gone, there will not be total loss of the accommodation. Accommodation will decrease. There will not be total loss of the accommodation. Okay, we are talking about the loss. The accommodation will be decreased because of the loss of convergence. Okay. Now the thing is, now Tranta dots easily ruled out. Next is melanoma. Melanoma is mostly not elevated lesion. In melanoma, you will not see the elevated lesion. Now, you will be confused about A and B because there is history of RA given. There is history of rheumatoid arthritis given. That is the thing. I did not remember, somebody answered A. Not answer is not A. That is I want to tell you here is, see, the most common scleral presentation seen with rheumatoid arthritis, scleromalacia perforans, is most commonly seen in RA. That is a correct statement. That scleromalacia perforans, most common cause is rheumatoid arthritis. True statement. But here the answer is not A. See, there here it is elevated lesions. Can you see there are elevated lesions? What is scleromalacia perforans? It is thinning of the sclera, which can go into perforation. Basically, staphyloma is basically the sequelae of scleromalacia. Scleromalacia is thinning of the sclera. So the lesion, the pigmentation or the blackish uveal tissue you are seeing here is, this black is what? Uveal tissue. In scleromalacia, it will not be coming outside of the eye. The lesion will be not excavate. It will not be raised. It will not be raised because here is just thinning there. The uveal tissue will be shining through the thinned sclera, but it will not be coming out of the eye. When it has come out of the eye, it is staphyloma. Okay, elevated lesion is staphyloma. If you see any elevated lesion, it is staphyloma. So the answer to this question is not scleromalacia, it is staphyloma. It has been previously asked this question, so just keep in mind elevated lesion will be staphyloma because staphyloma is outpouching of the uveal tissue. Scleromalacia is thinning of the sclera in which the uveal tissue is shining, but in staphyloma there is outpouching. So the answer is B. This is scleromalacia. In this there are not raised lesions. Okay, these are not raised lesions, just the uveal tissue is shining in the thinned sclera. So just make sure about this question. Whenever you see elevated lesion, the answer will be staphyloma. The answer will be staphyloma. Okay. Now, a diabetic patient with 6/9 visual acuity in right eye with retinal hemorrhages, neovascularization at disc. Neovascularization anywhere in the retina, either at disc or the elsewhere, other part of the retina. It is proliferative diabetic retinopathy, PDR. We know that diabetic retinopathy is non-proliferative. It is non-proliferative. It is proliferative. Any stage of non-proliferative, mild, moderate, severe, you just have to do glycemic control, wait and watch, follow up. PDR we treat. PDR we treat. Treatment of choice in PDR is pan-retinal photocoagulation. This is an easy question. You will mark pan-retinal. If the question, if one of the option was anti-VEGF, what will be the answer? Still the answer will be PRP. Anti-VEGF is the second line of treatment. Intravitreal anti-VEGF is second line of treatment. It is not the treatment of choice. Treatment of choice is only pan-retinal. Scleral buckling, treatment of retinal detachment. Treatment of retinal detachment. Now, what are this? These two can be confused. You know, you can say that it is only present at the disc. Why we are doing pan-retinal? We have to ablate the whole hypoxic retina. We have to do pan retinal. Then what are these focal laser and grid? These are done in diabetic macular edema. These are the treatments done in diabetic macular edema. Focal and grid are in diabetic macular edema. NEO-PDR is done pan retinal photocoagulation in any PDR, any neovascularization at disc, neovascularization elsewhere. But if in the question there is just macular edema, we'll go for focal or grid photocoagulation. Okay. Treatment of choices, PRP. Diabetes, very, very important question. I hope you are jotting down the important topics, because you have to study the whole topics, not just the questions. If the question is PRP, you have to study diabetes also. Okay, you have to study the etiopathogenesis, staging of the diabetes. You have to study everything. In this question, diabetic question, you have to study all the pupillary abnormal pupillary reactions. Okay, you have to study abnormal pupillary reactions, Marcus Gunn pupil, Ergil Robertson pupil, Holmes-Addis pupil. You have to study all. Okay, in this you have to study about the scleritis, you have to study about the necrotizing scleritis, non-necrotizing scleritis, episcleritis. So these are just some parts of the important topics you have to study. So I hope you are just jotting down the important topics. Okay, you have to study whole of the diabetic retinopathy. Now the next question is ROP is very important topic. ROP, etiopathogenesis, staging, treatment, very important. A preterm child of 31 weeks diagnosed with ROP, which is the most severe. See, zone decreasing, severity increasing, stage increasing, severity increasing, because we know that zone 1 is closest to macula. We have studied how do we divide the zones. We'll not go into the details. Zone 2 is farther away, zone 3 is the farthest, zone 1 is closest, so it is the most severe. Staging, we know that stage 1 just a demarcation line, stage 2 there is ridge formation, 3D height has been there, stage 3 there is fibrovascular proliferation in this ridge, stage 4 retinal detachment, partial retinal detachment, stage 5 is total RD. Okay, so these are the images. Demarcation line, proliferation of the disc, height has been added, there is vascularization at ridge, partial RD. Okay, this is APROP, this is APROP. Okay, aggressive progressive retinopathy, there is tortuosity of the vessel, so this is known as APROP. Okay, and this is the examination of the ROP. So ROP, next one thing, always just remember, because there is some confusion, you just write down the screening of ROP. Actually, the screening of ROP is different in the Western countries and Indian setup. So in India, any child less than 34 weeks and 200 grams, it is not 1500 grams or 32 weeks, it is 34 weeks and less than 2 kgs. In Indian setup, it is this. In Western, it is less than 32 and 1500. In India, it is less than 34 and less than 2 kgs of weight. We have to go for screening of the ROP. Okay. Now, next important in retina, diabetes, ROP. Next is retinoblastoma. Everything in retinoblastoma. This is just the treatment. You have to study whole of the retinoblastoma. Chemotherapy for retinoblastoma is vincristine carboplatin etoposide, VEC. In retinoblastoma, you have to study everything in retinoblastoma. You can be given B scan. You know, in B scan, there will be a mass present in the vitreous cavity, which will be showing calcifications. How do we recognize retinoblastoma on ultrasound? Is calcification is present. You have to study about the Knudsen hypothesis, two-hit hypothesis. Okay, you have to study the treatment. This is treatment, just the chemotherapy. When we'll go for enucleation, when the tumor has occupied more than 50% of the substance, we go for enucleation. If it is less than 50%, we go for chemo, we go for cryo. Okay, so you have to study whole of the retinoblastoma. Differential diagnosis of retinoblastoma, very, very important. White reflex, these are important. Okay. Next is shifting fluid seen in. So the next important topic in retina is retinal detachment, whole of the retinal detachment. Shifting fluid, there are three main types: rheumatogenic, tractional, exudative. RRD, primary retinal detachment. TRD seen in diabetes, ROP. Exudative seen in inflammations, like posterior uveitis, inflammatory conditions, tumors. Exudative RD. Rheumatogenic, primary RD after a tear, after retinal tear. Okay. Shifting fluid will be seen in exudative retinal detachment. Exudative retinal detachment, we studied about the Linkoff's rule in retinal detachment. Revise it, and also just revise which type of RD, if it is concave, whether it is convex, which type of RD is this. If it is concave, it is tractional. In shifting, it will be exudative. Okay. Vitreous detachment, what are the signs we see? We studied V sign is seen in our vitreous detachment. Ultrasound, funnel shaped RD. Okay, these are the some of the things you have to study in retinal detachment. Types of surgeries, buckling surgeries. Okay, these type of the treatment of the retinal detachment. So the whole topic of RD is also important. Basically retina, because in retina you will be asked 2 to 3 questions. In cornea, conjunctiva, 1 question will be asked, but in retina there will be 2 to 3 questions, so you have to study retina. Okay. The next is a contact lens wearer presented with watering, redness and photophobia from past 2 months. His clinical picture is given. Now you can easily rule out, yes, it is giant papillary because of the history, contact lens wearer. Now you can easily rule out trachoma and follicular because these are papillae are seen. These are the giant papillae. You can be confused between spring catarrh because in VKC also we see macropapillae. Okay, so just by clinical picture we cannot differentiate between A and B, but with the help of history we can go for GPC. So in VKC, along with the image, you will be like given that the patient has increase in symptoms in summer or spring, or it will be given like an adolescent age group of the child will be given in the question. Okay, there will be given ropey discharge. So these are some of the hints which will be given if the answer is VKC. Summer, spring, adolescent age group, ropey discharge. But in GPC, you will be given like contact lens wear history, or you will be given like patient was operated and there was suturing given, because protruded sutures can also give rise to GPC. Okay, so there can be history of suturing in the eye, or there can be history of prosthesis. There can be either contact lens wear history, protruding of sutures, or there can be prosthesis. Okay, prosthetic eye is there. So these all will give a hint about the GPC. Okay, so here the answer will be GPC, not just by the image but by the history. Okay. Now the most common cause of bilateral proptosis. Now most common cause in asked in adults, we know that most common cause of proptosis in adults, unilateral or bilateral, is thyroid eye disease. Thyroid eye disease. Okay, so the answer is thyroid eye disease. But in children the scenario is different. Unilateral, bilateral. The most common cause of unilateral is orbital cellulitis, and bilateral is metastasis. Mets, bilateral, orbital cellulitis, unilateral. Okay, so in children and adults. So in this question You have to study the whole topic of thyroid eye disease. What the whole topic? Lid signs, which we discussed already. Lid signs. This is the one-liner question. Treatment is not so difficult and also not that important because we have to give steroids only. The important things are the lid signs and the one-liner question about the causes of proptosis and the lid signs. Just remember the lid signs, learn them by heart. Okay, lid signs in thyroid eye disease. Okay. Now, the next is again the neurophthal question. This type of movement is lost in. Now, which type of movement is this? But firstly, this is the eye is adducted. The eye is adducted and elevation. So it is, what is this movement? Firstly, we have to do the movement is elevation in adduction. Now, to solve this type of question, basically in extraocular muscles, there are two main mantras you have to learn. You have to learn two main mantras and you will solve anything. First is sin and red, that is superiors are in tortoise, rectis are adductors. And this is the first mantra, and the second mantra is in the movement of elevation and depression, the recti are elevators or depressors. In abduction, I mean that is in abduction, their function of elevation and depression is maximum. While obliques, they show their maximum elevation and depression in adduction position. So the strongest elevators and depressors in adduction are obliques, and powerful elevators or depressors in abduction position, in abduction position are recti. So these are the main two mantras. You will solve anything. You will solve the PARC 3-step test. You will solve anything by these two mantras. Okay. So this is elevation in adduction. In adduction, the elevation is the function of obliques. And which obliques causes elevation? Inferior oblique. Inferior oblique. So inferior oblique function is lost in. The question is lost in. Inferior oblique is supplied by third nerve palsy. So the answer is third nerve palsy. Is it clear? This question is clear because the question is the movement is lost in. Okay. So firstly, you have to see which movement is this, supplied by which nerve, and then you will get the answer. So this is third nerve palsy. I hope it is clear to everyone. Okay. Next is the photostress test. Photostress test. So the important topic is macular function tests. There are so many macular functions tests, but the main important is the photostress test. As the name suggests, it is a stress test induced by the photo light. Okay, it is a test to differentiate, since it is a macular function test, as the name suggests, so it will differentiate between macula and optic. Now, what are we doing in photo stress? We are stressing out the macula by photo, that is by light. What we are going to do is we'll ask the patient to read Snellen chart from 6 meters. Okay, normal Snellen visual acuity will record. Okay, then we will stress his photoreceptors by showing a bright light, like we'll show the bright light of indirect for 15 to 20 seconds, and after 15 to 20 seconds we'll measure the visual acuity of the patient again. What we are doing is we are bleaching the photoreceptors by the light. We are bleaching the photoreceptors by light. Okay, and we will we'll record his visual acuity again by after 15 to 20 seconds. The normal recovery time is 15 to 30 seconds. The normal recovery time is when we have bleached the photoreceptors of the patient. Firstly, we'll ask the patient to read the vision. Okay, then we will shine a bright light into his macula for a few seconds, and then after 15 to 20 seconds we'll ask the patient to read the Snellen's chart again. If the patient is normal, there is no macular disease, he'll again read the same Snellen chart which he read earlier. So the normal recovery time of the bleaching of photoreceptor is 15 to 30 seconds. So we'll ask the read to read him after 15 to 20 seconds, and the patient will read it normally. If it is he's not reading that normally, that is there is some problem in the macula. If the Photostress test is positive, that is after 30 seconds he's not reading the same line on Snellen's, his what is the defect in macular optic nerve? The defect is in macula. So it is a type of macular function test. So again, the next topic you have to read is macular function test, that is the Photostress test. It is a stress given to eye with light. We are bleaching the photoreceptors. Okay. Next is prerequisite for sympathetic ophthalmitis, penetrating injury. Very straight liner question. What is sympathetic ophthalmitis? Is basically it is a type of granulomatous uveitis. Basically, the body has identified the uveal antigen or you can be given penetrating injury, or you can be given intraocular surgery. Okay, intraocular surgery involving the uveal tissue is also a prerequisite. So the eye has identified the antigens, so it will act against the uveal tissue of the other eye. Both of the eyes will develop granulomatous uveitis. Both of the eyes will develop granulomatous uveitis. Okay. So the prerequisite is penetrating injury. Two things important to learn in sympathetic ophthalmitis is first sign and first symptom. Again, two important one-liners in SO is first sign. Anybody can please, if you write down first sign and symptom. Till then, we'll go to the next question. Characteristic features of fungal corneal ulcer. Can anybody please write down the first sign and symptom of sympathetic ophthalmitis? No? Okay. The first sign is loss of near vision. Yes, loss of accommodation, loss of near vision. First sign is retrolental flare. Okay, first sign and first symptom. Very important topic in cornea is ulcer, and in ulcers, fungal ulcer are most commonly asked. Characteristic of fungal ulcer, straight liner question, satellite lesion, very characteristic. You will be given history of trauma with vegetative matter, like animal tail, twig of a branch or twig. Okay, signs will be more than symptoms. Patient will not be having so much pain, but on a slit lamp examination, so many signs will be there. This is the main lesion. There will be some satellite lesions will be there. Hypopion will be there. Very characteristic about the hypopion of one first sign is retrolental flare, that is vitritis. It is vitritis. And first symptom is loss of near vision. Yes, enucleation is done to prevent the chances of sympathetic ophthalmitis, because the sympathizing eye develops span uveitis usually after some weeks. The normal time is 2 to 3 months. So we just try to enucleate as early as possible. We try so that the other eye does not get affected. So two things characteristic about the hypopion of fungal ulcer is it is non-sterile and immobile. Okay, it is immobile. Because of the hyphae, it is immobile. Okay. Also learn about the viral ulcer, dendritic lesions, causes of dendritic ulcers. Okay. Next is which vitamin is in supraphysiological doses causing macular edema? Factual question, niacin, vitamin B3, niacin, because it activates prostaglandins, which breaks the blood retinal barrier, causes cystoid macular edema. But the important topic is cystoid macular edema and its differential. What is the most important differential? CSR. Do study both CME and CSR. Okay, CSR and CME causes. Do we need to give? Yes, we give antivirals. We give acyclovir to the patients. Okay, we give ganciclovir to the patient in viral corneal ulcers. This type. Okay, we'll come to this question in the last. Let us. We have only 2-3 questions left. 21 question in the last. Okay, this is which nerve palsy is this? If you are given this type of question in which so many gazes pictures are given, first just go to the central image. Always see the central image first. Tosses. No need to see the other images. It is third nerve palsy. Still we can see this. Eyes down and out. Abduction is compromised. Abduction is defected. See here, abduction is defected. Okay. See, this is the clinical picture, characteristic of third nerve palsy. Even the just always see the central image. It will give you you will solve the 70% of the question by just seeing the central image. Okay, third nerve palsy. 100-ray glaucoma, very important. CRVO. What is happening in CRVO? There is so much hypoxia because of the hemorrhages. There is increase in VEGF, which causes neovascularization, which causes neovascular glaucoma, which is a type of secondary glaucoma, which is a type of secondary open angle glaucoma. 100-day glaucoma seen after 3 months. So 100-day glaucoma. Study about CRVO, CRAO, cherry red spots, differential diagnosis of cherry red spots. So the important topic, CRVO, CRAO, treatment of them, anti-VEGF, CRAO treatment, very important. Very commonly asked treatment of CRAO or study. Okay, the most serious cause of conjunctivitis causing blindness in child. There are two straight liner question, most serious and most common. Actually in 2000, this is a 2018 question. Most serious is gonococcus because it can affect the cornea. It can cause corneal perforation. So it is most serious. But most common cause is chlamydia. Most common cause is chlamydia. Okay. A lady presented with 1-day history of sudden painless loss of vision. It is painless. On examination, RAPD is there. Rest ocular examination was normal. Spot diagnosis, optic neuritis, retrobulbar neuritis, RAPD. In optic nerve diseases, RAPD is the rule. Which investigations are helpful? MRI, estimation of blood glucose, anti-NMO, anti-MOG antibodies, thyroid profile. We'll do the MRI because we know that the most common cause of optic neuritis is multiple sclerosis. Yes, we'll do the MRI. Whether we'll do the blood glucose level, RFT, LFT, yes, because in optic neuritis, what is the treatment of choice? Intravenous steroids. High dose methylpred for 3 days. Then we give oral methylprednisolone for 11 days. Then we taper it. So there is so much long treatment of steroids. We have to determine their glucose levels. It raises the blood glucose level. So we have to study his RFTs, LFTs, glucose levels. 1 is right, 2 is right. Anti-NM, if there is not recurrent optic neuritis, if there is no history of transverse myelitis is given, no need to do an NMO because it is neuromyelitis optica. Yes, it is for treatment only, na? Because we have to treat the patient there and then only. If you diagnose optic neuritis, you will give him as soon as possible methylpred. So you must know na, whether the patient is diabetic or not. Okay, if the question is asked to confirm the diagnosis, okay, the options, this is a previous year INI question. Okay, yes, if it is asked to confirm the diagnosis, answer will be 1 only, but there are no options in this now, so we have to, only 1 option is not given, so we have to treat the 1 and 2 option. Okay, if the answer yes, right, if the option, one of the option was only 1, then the correct option will be 1 only, but it is a group of options is given, so the most appropriate is 1 and 2. What I'm telling is it will not be 1, 2, 3, 4, because NMO, if it not recurrent optic neuritis or it is not history of transverse myelitis is given, we do not have to undergo battery of investigations. Okay, we'll just give him estimation of blood glucose levels and MRI. Okay, so the answer will be 1 and 2. Yes, you are right, because if the answer option was only 1, then you have to tick the option given as only 1, because for the diagnosis we want only MRI, but since we have to treat the patient also, we want his blood glucose level. So out of these options, the most appropriate is 1 and 2. Okay, there is no need of going 3 or thyroid profile, so the answer should not be C but A. I hope it is clear. Okay. Now we come to the last question, visual field defect. This type of visual field defect. Okay. Now, I hope you are well acclimatized to these types of definitions. Okay, I hope you know these type of definitions. If you still don't know, take a picture of this. What is hemianopia, quadrantopia, homonymous is same side of the visual space. Okay, same side, not the same side of the retina affected, same side of the visual space. It is, suppose this is left, this is right, so this is one left, this is right, this is left, right, so this is the same space, this is the same space, homonymous. This is heteronymous. Although we know that homonymous hemianopia is basically the fields are opposite, but since it is the visual space is same, so it is homonymous. In heteronymous, it is opposite space. Don't get confused between them. Okay, congruous is symmetrical. This is congruous lesion. In incongruous, it can be like one is hemianopia, one is quadrantopia. It is incongruous. Okay, now screen is not moving. We'll look for the visual field defects. See, if it is central scotoma, examples of central scotoma, any optic nerve disease, can be like CRAO, any disease causing the lesion of the optic nerve, CRAO, CRVO, they will give central scotoma. Okay, macular diseases, they will give central scotoma. Next is the optic nerve. Whenever there is lesion of the optic nerve, one eye will be involved because there is no, because the chiasma has not happened yet. There is no fibers have not gone to the other side. So it will be affection of the one eye only. Okay, the total loss of the vision in one eye. Next is whenever there is chiasmal lesion will be there, because the chiasma now includes the nasal fibers of one and temporal fibers of the other. So it will be nasal of the one will be affected and temporal of the other will be affected. So it will be homonymous. It will be homonymous because the same side of the visual space is occupied. So it is homonymous bitemporal hemianopia because the nasal fields are affected. In chiasma, what is happening is that temporal are on the same side, nasal have decussated. Now we know that nasal field or the nasal fibers make the image of the temporal side of the eye. Okay, so the nasal fibers will give the defect on the temporal side. So it will be bitemporal hemianopia, homonymous bitemporal because the nasal fibers have gone. In after the optic chiasma or from the optic tract onwards, you just have to remember that after optic tract onwards, there will be what type of homonymous? Contralateral hemianopia. There will be contralateral hemianopia will be seen. Okay, this will be contralateral because same space is defected. So it will be contralateral homonymous hemianopia after optic tract till the end. In lateral geniculate body, in the visual cortex, it will be homonymous hemianopia. Quadrantopia will be seen in the parietal and the temporal lobe. It will be seen in the parietal and the temporal lobe. It is pie in the sky. It is pie in the floor. Pie in the sky is MIT. The temporal fibers are present inferiorly as Mayer's loop. Mayer's loop, inferior fibers, temporal. So which field will be gone? Superior field will be gone in the temporal. Okay, temporal superior field will be given pie in the sky. In the parietal lobe is Baum's loop or the Baum's fibers, which are superior, gone in the parietal. So the superior fibers will give inferior loss of field, inferior field loss. So it will be pie in the floor. This is the macular sparing. This is the same side, macular sparing homonymous hemianopia. Macular sparing homonymous hemianopia seen in the occipital lobe diseases, because occipital lobe is supplied by PCA and MCA. Whenever MCA is intact, the macula is spared, because macula is supplied by M for macula, M for middle cerebral artery, and occipital lobe mainly supplied by PCA. So whenever there is loss of PCA supply, it will be homonymous hemianopia, because same side, homonymous hemianopia, which is maculary sparing. Okay. So from the optic tract, it will be homonymous lesions will be there after the optic tract. So the question was asked about the pie in the sky, which is temporal lobe, pie in the sky. Okay, so visual field defects. So these are the main important topics you have to study. I think we have completed the questions. Yes, so we have completed the question. So yes, I'll share the PDF to you. KPs. Okay, see, in uveitis there are two main type. What are KPs? Are basically present on the endothelium. These are the aggregates of inflammatory cells. These are the aggregates of inflammatory cells like lymphocytes, plasma cells, okay, macrophages. All these inflammatory cells, they make KPs, which are present on the endothelium of the cornea. Because of the presence of gravity, they are located in the inferior part of the cornea in the form of a triangle, which is known as Olds triangle. Now there are two type of uveitis: granulomatous, non-granulomatous. In non-granulomatous uveitis, the KPs are fine. In granulomatous, the KPs are mutton fat KPs. Okay, they are mutton fat KPs. In any question, if you are given about a systemic disease, just go for the thing that this uveitis is granulomatous. Systemic disease mostly have granulomatous uveitis, and the other idiopathic or the other causes of the uveitis have non-granulomatic. Okay, these are the type of KPs which are formed from the inflammatory cells. ROP question will be ROP, the most we were asked about the most severe, no? So in which so see, zone 1, because zone 1 is nearest to macula. Two options have zone 1, stage 1 or stage 3. Whenever the stage is more, the severity will be more. So the answer will be stage 3, zone 1. When the zone decreases, severity increases. Stage increases, severity increases. So the answer will be stage 3, zone 1. So these are the important topics. Just jot down the important topics also which you have to learn, and you are free to text me anytime. You can text me on Facebook or WhatsApp. I'll try to help you out as soon as possible till the exam happens. Any topic, any query, any MCQ you are solving, you can message me anytime. I'll try to solve it. Okay, and so these are some of the important topics. 10 to 12 question will be asked, so jot down the important topics. I'll share the PDF, and all the best to you, and just keep on revising. And this is not the time for starting the new thing. If you have left anything, just revise the things you have covered. Okay, just revise the things you have covered. No need to start new. Just revision is the key at this type of time. Okay, and feel free to text me anytime. Fine. So this is for today. I hope you found it useful, and this session proved to be a useful session for you. Thank you. Okay, I'll share the PDF. Don't worry. Thank you, and all the best to all of you. Thank you. Thank you. Visual field defect. Always learn by heart. Visual field defect, glaucoma, pharmacotherapy, and retina also. Okay. Fine. Good night. Good night to everyone. Thank you. Thank you.